Before getting started, I want to take this opportunity to thank the organizers of this symposium for inviting me to participate. In the next session, what we will be discussing is dietary treatment options in eosinophilic esophagitis. I am Dr. Eithan Rubestein, Assistant Professor in Pediatrics at Harvard Medical School and an attending physician at Boston Children's Hospital. As part of my role at Boston Children's Hospital, I am part of our eosinophilic gastrointestinal disorder clinic, which is a clinic dedicated to management of allergic conditions in the GI tract. It is a combination of gastroenterologists, allergists, dietitians, social work, and nursing. I have no personal financial disclosures or conflicts of interest to report at this time. What we will be discussing in the next session is initially background and clinical presentation of eosinophilic esophagitis. Then we will transition to understanding the approach to dietary management in eosinophilic esophagitis, review the available restriction options, and then discuss the downsides of dietary therapies in eosinophilic esophagitis. Starting off with a little bit of background. We know that eosinophilic esophagitis is a chronic progressive Th2-mediated inflammatory condition. It involves the esophagus with a prevalence of about 1 in 2,000 people. Now, this is not the most common or prevalent condition in gastroenterology, but as you can see, this is not an uncommon condition, and it is something that we treat frequently, particularly in our center. We know that it is more prevalent in males, 3 to 1 across multiple studies, and it typically presents in patients who have other atopic conditions such as asthma, food allergies, and eczema. It's characterized by clinical symptoms of esophageal dysfunction and histologically by the presence of eosinophils. Now, what we have learned over the last 20 years or so is a lot. Basically, when we started off in the field, the initial studies revolved around identifying certain genes that were upregulated and downregulated. That allowed us to build a map with likely candidates and pathways for the inflammatory response that we eventually see histologically. On a cellular basis, EOE is almost always triggered by a food antigen trigger, which becomes important when we are talking about dietary restrictions. These antigens trigger a Th2 inflammatory cascade by interacting with esophageal epithelium, which then lead to the production of pro-atopy cytokines such as IL-33 and TSLP. This then activates T regulatory and Th2 cells, leading to pro-inflammatory cytokines such as TGF-beta, IL-4, IL-13, and IL-5, which recruit eosinophils, elicit barrier disruption, tissue remodeling, and eosinophilic inflammation. Now, as far as disease progression, we know that initially the eosinophils lead to, or at least are present during a mostly inflammatory response, which is what we typically see in our younger patients, infants and young children. As time goes on, if left unchecked, the inflammation can lead to fibrosis and subsequent esophageal remodeling, leading to esophageal strictures, which can then cause food impactions. Diagnostic delay may increase the risk of fibrostenotic complications, which is why a high index of suspicion with symptoms should be had, and when present, the disease should be treated. Let's talk a little bit more about the clinical presentation. We know that the symptoms, just like the inflammatory response, tends to vary or switch with age. In younger kids, The symptoms are more consistent with feeding difficulties and vomiting. As kids get a little bit older, abdominal pain and heartburn become a little bit more prevalent. And in early adulthood, the more prototypical dysphagia and food impactions are seen. Aside from the classic symptoms, as gastroenterologists, it is important to recognize other symptoms that can also be seen, specifically chronic refractory cough, frequent throat clearing, recurrent croup, hoarseness, and subglottic stenosis. We will now move on to the next portion, which is really disease management of this condition. Now, therapies in eosinophilic esophagitis can be broadly characterized into one of two main categories: medications, of which we have a few, proton pump inhibitors, swallow topical steroids, and biologics. During this session, we will not be discussing the medication management of eosinophilic esophagitis, but instead we'll be focusing on the other approach, which is the dietary elimination approach to management of eosinophilic esophagitis. Even before we truly understood the pathophysiology of eosinophilic esophagitis, it was noted that food antigens were the likely trigger of the inflammatory cascade. Kelly, in his paper in 1995, along with his colleagues, evaluated a group of children with refractory reflux symptoms. There were 23 patients, children, who had symptoms of gastroesophageal reflux disease and marked esophageal eosinophilia. Those patients had undergone several therapies, such as fundoplication, in attempts to manage their inflammation, which at that point was thought to be related to uncontrolled gastroesophageal reflux disease. 17 of these patients were offered dietary therapy, and 12 of those completed the trial. 5 were not compliant with the exclusive elemental diet and were discarded. Of the 12 who completed the trial, 10 had resolution of their symptoms, and the other 2 had improvement. This occurred within 3 weeks of the start of the trial. The 10 patients who agreed to having a repeat endoscopy all had significant improvement in their esophageal eosinophilia. This was a seminal paper in establishing the role of food antigens resulting in the inflammatory changes which we see in eosinophilic esophagitis. So with this in mind, and with the understanding that food antigens are the major trigger of this condition, the next obvious question is, okay, if food is what's triggering this, what's the best diet to manage this condition? And there are a few options. Elemental diet, as was used in the initial trial by Kelly and his colleagues, test-directed elimination diets, and empiric elimination diets. We will be going through those one by one, starting with elemental diets. We know that elemental diets are by far the most effective dietary management in eosinophilic esophagitis. By removing all food antigens and instituting a 100% elemental diet, we know that the response is extremely high. Most studies mentioning over 90% and close to 95% have done exclusively. This analysis or meta-analysis by Arias and his colleagues of 13 studies, including a total of 429 patients with eosinophilic esophagitis, 411 of which were children, evaluate the efficacy of exclusive feeding with an amino acid-based elemental diet. Of these, 12 studies were carried out in children and only one in adults. The overall efficiency of elemental diet in achieving histologic remission of eosinophilic esophagitis was almost 91%. Although the data for adults are limited, the response rate was very high in both children and adults, with moderate homogeneity among results from the different studies. While it is clear that this diet is effective and successful in a vast majority of children and adults, there are major drawbacks. We will discuss the, quote, side effects, end quote, of dietary therapies later in the talk, but I think specific emphasis should be placed on the major drawbacks of this approach. First of all, the palatability issues of elemental diets make this approach difficult for most of our patients to be able to carry out orally, resulting in most of our patients requiring either a nasogastric tube or a gastrostomy tube to get enough calories and nutrition to sustain themselves on a fully elemental diet. The cost is also important. This is a very expensive formula. Many insurance companies, most at least in the United States, will not cover elemental formulas. But aside from the expense of the formula itself, these diets, which usually require repeat endoscopies in order to map out what the triggers are, can lead not only to issues with the endoscopies themselves, but the expense of repeat endoscopies, which also need to be taken into account. Probably the most significant drawback, at least in my mind, relates to the social and psychological impact of this approach. While, as we will mention later, this applies to all of the restriction options, it is especially severe in regarding to this approach. But again, we will visit this moving forward. Moving on, test-directed elimination diets are another option. If elemental diets are not usually a good choice, and we know that eosinophilic esophagitis is an immune antigen-mediated disease, and that antigen is almost always food, can we use our available tests to try to figure out what antigens are leading to the inflammation in specific patients? The allergy testing most often used by our colleagues in the field of allergy and immunology are skin prick and serum IgE testing. While this is effective in evaluation of IgE-mediated food allergies, we know from studies that while eosinophilic esophagitis is in fact an allergic condition, IgE does not seem to play a major role in its pathogenesis, at least a central role. This is known both by lack of response to therapies that target IgE and by poor clinical response to therapies using this approach to dietary restriction. Well, what about patch testing? This entails placing food proteins on patches, leaving them on the skin for 48 hours, and then assessing a response. Initially, this led to excitement in the possibility to identify allergic triggers in eosinophilic esophagitis. Unfortunately, as was the case with skin prick testing, while initial studies showed good promise, repeat studies showed that this also was not seen to be an effective strategy, and food atopy patching testing has not been standardized or validated. So what do we know about the studies conducted specifically looking at this approach? This meta-analysis done again by Arias and his colleagues looked at 14 different studies using this approach. This was carried out on 626 patients, mostly children. Overall, the efficacy was a little bit under 46%, but with a wide variability, particularly between children and adult, showing in some adult studies a response of only about 26.6%. Now, the the effectiveness of this therapy seems to increase a little bit, or actually quite a bit, if you combine empiric restrictions, mostly dairy, with diet restrictions based on allergy testing. But that seems to defy the purpose of using tests to try to determine the main antigens driving the inflammatory response. Moving on to what is probably the most common, or I would say the most common therapeutic approach to eosinophilic esophagitis, we'll move on to empiric elimination diets. In clinical practice, we know what foods tend to be the most allergenic. These include cow's milk, or dairy, eggs, wheat, soy, peanuts and tree nuts, fish, and shellfish. In 2006, Kagawala and his colleagues looked to see how effective this, quote, 6-food elimination diet would be in controlling eosinophilic esophagitis. I say, quote, 6-food elimination diet because in reality we are talking about 8 foods if we don't combine peanuts and tree nuts, fish, and shellfish. Well, in this study of 26 of the 35 patients that were evaluated, 74% had remission achieved by the avoidance of these top 8 allergens. Now, in a subsequent study in 2011, what they did was first have patients go into remission with a restriction diet, and then tried to distinguish what the higher allergy foods or what the most common triggers were. What they noted in this study was a few things. First of all, they found that there was a single offending food antigen identified in 26 of the patients, so 72%. 2 foods were identified in 8% of the patients, 3 foods in 8% of the patients also. They also, by looking at histologic response with food introductions, noted that cow's milk was by far the most common antigen trigger, being a culprit in 74% of the patients. Wheat was second on the list at 26% of the patients seemed to have wheat as a trigger. Egg was present in 17% of the patients as a trigger. Soy in 10, peanuts in 6%. Now, using a meta-analysis, Arias looked at the available data, and this is from 2014, but using, again, the meta-analysis, Arias reported combined histologic response in 7 studies using 6 or 8 food elimination diet to be around 72%. This response was similar in pediatrics than in adults. With the knowledge that cow's milk protein is by far the most common food antigen trigger in the inflammatory response in eosinophilic esophagitis, subsequent studies have looked at different approaches to empiric restriction. In this case, what would happen if we just avoid dairy and not all the other potential triggers? This was, in this prospective observational study, families were instructed to avoid all cow's milk protein and subsequently had repeat endoscopies done. Of 41 patients assessed, 51%, so a little bit over half of them, had histologic remission, which was defined by less than 15 eosinophils per high power field. 59% had endoscopic remission, and 61% had symptomatic remission. In a better attempt to compare single versus 4 food elimination diets, knowing that the single food elimination diet of dairy can be successful, This prospective, non-blinded, randomized, multicentral trial was conducted involving 10 sites in the United States and recently published as of last year. Participants were randomized to either 1 food elimination diet or 4 food elimination diet, and after 12 weeks underwent a repeat endoscopy. The primary endpoint was symptomatic improvement from baseline measured by a parent proxy PEESS scale. The secondary endpoints included patients achieving histologic remission, which was defined as less than 15 eosinophils per high power field, quality of life scores, and biomarker response. 63 patients were enrolled and 51 completed the initial phase. The symptom score, as reported by parents, was better in the 4 versus 1 food elimination diet, but there was no statistically significant difference when patients themselves were asked about the difference in symptom score. Histologic remission occurred in 41% of patients who underwent the 4 food elimination diet and 44% of the patients where all they avoided was dairy. The authors of this study also looked at gene signature changes and noted that between those that responded, 1 food elimination diet versus 4 food elimination diet, the changes in genetic signature were similar. Also, in those that didn't respond to 1 food versus 4 food, those genetic changes were also similar. What was also noted and interesting, but maybe not surprising, is the percent of patients where dropout was noted. The withdrawal rate in patients who were assigned to the 4 food elimination diet was 32% compared to 10% when only 1 food was restricted. This is despite having significant support from the study coordinators, including dietitians. The major cited reasons for withdrawal from this study, at least based on what the authors report, was difficulty with the diet and expense. Now, we know that from the IgE food allergies, particularly to dairy, that a portion of patients who have allergic responses to milk protein can tolerate it in the baked form. With this in mind, Dr. Luong and his colleagues wrote a letter to the editor in which they tested this phenomenon in eosinophilic esophagitis. What they did was 6 weeks incorporation of baked milk, 3 to 4 servings per day, in patients who had obtained histologic remission with milk protein-free diets, known to be the only trigger in this subset of patients. The baked milk was given in the form of bread, muffins, cakes, and brownies. And what they noted was that 73%, so 11 of the 15, maintained histologic remission with this strategy. A more recent case report published in 2019 also demonstrated the feasibility of baked milk introduction as an option for subsequent to patients where milk protein in the unbaked form was known to be a trigger for EOE. In this case report, 6-week milk elimination diet in conjunction at this point with a proton pump inhibitor and a repeat endoscopy had shown that the previous eosinophilic esophagitis had resolved with a milk protein-free diet, indicating that milk was the main food antigen trigger driver of the disease in this patient. In addition, the patient also reported no symptoms at the time of the endoscopy when milk protein-free was removed. With this, knowledge, the patient was then advised to consume baked milk in the form of a muffin every alternate day for 6 weeks, and a follow-up endoscopy was then done and noted to be mostly normal, with a peak eosinophil count of 4 eosinophils per high power field. So with all this knowledge, we the next question is, well, what is the best approach moving forward? Is it a step up therapy in which you start with a low, a more limited restriction and move your way up? You start with 1 to 2 foods, 6 weeks. If that doesn't work, go to 4 foods. If that doesn't work, go to 6 or 8 foods. Or is the or the alternative of starting with a bigger restriction, or eliminating 6 foods for 6 weeks and hoping to achieve remission. If you achieve remission, then you get reintroduction 1 food at a time to kind of, as we call, map out what the triggers are. Now, there's advantages and disadvantages of each of these therapies. The advantage of the step-down therapy is remission may be achieved in a shorter time period, but the major disadvantages generally means more endoscopies, and it's more restrictive, at least at the beginning. The step-up therapy, the advantages are identifying responders to 1 or 2 food eliminations more quickly, less restrictive, and potentially fewer endoscopies, but the disadvantage is the potential prolongation of ongoing inflammation in the esophagus, which is especially important when symptoms are significant. We know that the scarring, the reason we treat eosinophilic esophagitis, I usually tell my patients in the short term is to control the symptoms, but in the long term is to control inflammation. The inflammatory response tends to lag quite a bit, but symptoms, especially for our patients that are extremely symptomatic, achieving an earlier remission is often preferable. Now that we've reviewed all the diets, I think it's helpful to have 1 or 2 slides where they are compared side by side. I like this recent published article, which was a systematic review and meta-analysis of histologic remission comparing the different diets. Any diet, the overall effective remission rate was about 60, almost 61%. Exclusive elimination diets, close to 95%. 6 food elimination diets, 64%. A 4 food elimination of almost 55%. 2 food elimination diets of 44%. 1 food elimination diet of 46%. And as mentioned, allergy testing directed at food therapies, which is not surprising, at the lowest histologic remission at slightly under 40%. This is another chart that I like to review with my patients when discussing the options. Again, the previous was more of a meta-analysis or combination of the different studies. I like this because it gives you a little bit more of a range. And as you can see, depending on different studies, some of them are, I guess, more rigorously performed than others. You can get very different percentages of patients undergoing remission. Elemental diets anywhere between 74 to 100%. 6 food elimination diets, you see this wide range from 40 to 80%. 4 food elimination, milk, wheat, egg, and soy, again 40 to 65%. Dairy on its own, ranging from 34 to 51%. Test-directed elimination diets, which is mentioned several times up to this point, tend to be the least effective. But the the effectiveness of these diets can range anywhere between 35 and 57%, but that number goes way up when you combine test-directed elimination with avoiding dairy. Again, these are hard to interpret because of the variability in study designs. I think the important thing when reviewing the dietary options are taking into account patients' specific needs, and not just the patients but the family specific needs. You really need to ask what is feasible as a first therapy, or I guess as a first question when reviewing the diets. If you know that a patient or a family is not able to do more than one or two food restrictions because of either financial issues or quality of life issues or family issues, then some of the options which are more restrictive aren't really feasible. On the other hand, if families are extremely motivated and they want to understand what the triggers are, the more restrictive diets and the mapping out of what the potential triggers are may be more feasible for that group. Again, I emphasize the importance of individualized treatment and spending time with our families, understanding what their limitations are, what their thoughts are before moving forward. These are not one-size-fits-all therapies. And although we are not talking about medications in eosinophilic esophagitis, for some patients it's important to realize that even if you can achieve remission with dietary interventions, this might not be a feasible option. And this leads us to the last part of the talk that we're going to be having here, which are what are some of the potential drawbacks. We know that they work. We know that some are more effective than others. We know, particularly for elemental diets, that they're extremely effective, and even more limited diets of dairy on its own, which are, in our mind, something that's a little bit easier. It's important to know that there are significant drawbacks that need to be reviewed and discussed with families. As physicians, we are very comfortable talking about side effects of medications. We can talk about adrenal suppression and infections and increased risk of malignancies. What we may not be as comfortable or as trained in is discussing, if we want to call them side effects or factors to consider of dietary approaches. We know that dietary approaches tend to almost definitely lead to more endoscopies than when we do medication for the management of eosinophilic esophagitis. There is the significant expense that goes along with it. Again, foods, restricting the diet might seem like an easy thing for some people, but it's important to know that this can be very expensive. The shopping can get very expensive, and in some of the studies that have been done, one of the major drawbacks to the dietary restriction approach for families has been the expense of needing to shop with restriction diets in place, as some of the particularly dairy alternatives tend to be a little bit pricier than dairy when dairy is not in the diet. We have to take into account as pediatricians, not just gastroenterologists, what the effect on growth and weight gain can be. And then we always, and one of the things that I really spend a lot of time talking to my families who are considering dietary interventions are the psychological impacts. And we'll review that a little bit more when we're talking about the studies that have been published, but feeding issues, eating issues, and more importantly, quality of life. One of the stories that I tell my patients when they're considering dietary elimination diet is the story of a young child who had eosinophilic esophagitis, and I was following in my clinic. and that we identified dairy as a trigger for his eosinophilic esophagitis. He did have several other food allergies, peanuts and tree nuts, but we started him on an elimination diet. His eosinophilia was in remission with a dairy-free diet, but family noted that he started to withdraw. He was an avid soccer player, and decided that he no longer wanted to play soccer. And on questioning by the family, it turned out that his soccer team would go out for pizza after games. Since he couldn't have pizza with his friends, he decided to quit the team. And, that's might seem like a small thing to us, but I think it's important to consider when we're talking to our families that there are significant potential psychological impacts, particularly quality of life to patients, and that's something that needs to be discussed before any diet gets implemented. More recently, as we will talk about moving forward, there has been some reports of IgE sensitization to previously tolerated foods. So, talking a little bit about the effects of growth and weight, we know that children with food allergies frequently have low intake of micronutrients. Now, while that does not necessarily lead to deficiencies, it is important to keep this in mind. A lot of the studies, particularly with avoiding milk protein, have noted low intakes of calcium. We know that dairy is a very good source of not just calcium and vitamin D in our pediatric population, but of protein and calories. Other deficiencies, such as vitamin D, zinc, iron, and fatty acids have been reported, but less commonly. And at least in the United States at this point, there's no established guidelines on how to monitor for micronutrient levels. Looking at this chart, you can see, if you just look at the foods that we often restrict in eosinophilic esophagitis, cow's milk being the most common. I mentioned, particularly in our patient population, they are often a very significant source of protein, calcium, vitamin D, but other micronutrients such as magnesium, phosphorus, and different vitamins. In some countries, iodine is also important as iodine is placed in milk as a fortification. But soy, eggs, wheat, peanuts, tree nuts, fish, and shellfish are also important to note that they are a very good source of a lot of micronutrients. And when restricting these proteins from the diet, we could sometimes, in some certain circumstances, be causing more harm than good. Compounding the nutritional issues with restricting food from the diet, we also know that even prior to our restriction, a number of our patients with eosinophilic esophagitis come to us with already some feeding issues even prior to any of our interventions. This study by Mukada of 200 children ages 1 to 9.5 with eosinophilic esophagitis was what they noted was that almost 17% of the patients had some sort of feeding disorder. Of those, 93% had learned adaptive maladaptive feeding behaviors with food refusal, low volume or variety of intake, poor food acceptance of new foods, spitting out of foods, grazing, lack of mealtime structure requiring prompting to eat, inconsistent patterns of eating, and the feeding difficulties resulted in deficient oral intake, leading to malnutrition and growth distribution in about 21% of these patients. Now, the feeding difficulties we know are prevalent in our patients with eosinophilic esophagitis. And it's important to note that sometimes these restrictive patterns or these feeding issues can linger even after the inflammatory condition is resolved. These are adaptive and very difficult to overcome for a lot of our patients. So you can you can be sure that a patient who has been subsiding on dairy for their major nutrition, just because their eosinophilic esophagitis is controlled, does not mean that they'll automatically open up to other substitutes such as soy or pea proteins. Making that point, this short communication from 2019 highlighted 2 cases of ARFID in patients with diet-treated eosinophilic esophagitis. Now, the reports are scattered about the impact of diet restriction on patients, but I can tell you that in my practice, a lot of our children with food restrictions do develop issues with withdrawal. As I mentioned, my patient who, was an avid soccer player and decided to quit, but withdrawal and depression. But this is not something that we see universally, which is why I don't think that this is that diet restrictions should never be implemented or never be offered to families. I think it's just important to screen families and screen patients before instituting these therapies because of these risks. For some patients, they don't mind being the one to bring their own cupcake to a party or restricting their diet. They might be used to it because a lot of our patients have other food restrictions. But for some, this is an important issue that needs to be assessed. There have been reports not just of ARFID with our patients, but eating disorders or disordered eating in patients as they start to see food as the enemy, start to restrict certain foods. It's a very slippery slope that needs to be monitored during visits. As mentioned in our initial slide when we were reviewing some of the risks of dietary restrictions, there have been case reports of development of IgE-mediated hypersensitivity to foods previously tolerated. Now, this data was initially reported in patients with atopic dermatitis with diet restriction, but there have been case reports in eosinophilic gastrointestinal disorder conditions. Ho and colleagues reported did a case report of 5 patients with eosinophilic gastrointestinal disorder, which responded to milk protein-free diet. These patients were tested prior to the restriction diet and noted to have no skin prick testing positivity to milk protein. They had also been consuming milk protein without issues prior to their restriction. When reassessed after milk protein was removed in an attempt to manage their eosinophilic esophagitis, what was noted was that all 5 of them, after having the milk protein be removed from their diet, showed a positive skin test to cow's milk. Of note, 2 of the 5 who had an accidental exposure to milk protein following the restriction developed symptoms, one of them with urticaria and the other with oropharyngeal itching. A separate report by Hill also noted a patient who had previously been identified to have cow's milk protein as their trigger for eosinophilic esophagitis, with healing of the esophagitis with milk protein restriction, which he had been consuming previously. After 2.5 years of being restricted of the protein, he then had an accidental exposure to milk protein and noted to have symptoms with oropharyngeal edema, which required therapy with an antihistamine. Again, this was a patient who, prior to eliminating milk protein from the diet, had tolerated the protein without any clinical symptoms, and then develop this more IgE-mediated reaction with an accidental exposure after a couple of years of restriction. While diet restrictions can be very effective and a good strategy for a subset of patients, it is important to be mindful of the potential drawbacks so as to maximize the chances of success while minimizing some of the potential negative impacts. I think it is important to think about having doctors that are experienced and specialize in the area, having accurate evaluation of eosinophilic esophagitis and concomitant conditions, having personalized diet therapies, which are important. Multidisciplinary team is very important, at least in our center. As I mentioned at the onset of our talk, we are lucky enough to work with social workers and dietitians, allergists and nurses to help. And the multidisciplinary team is, we think, an invaluable part of clinics. We are spoiled. I understand that not everybody has access to some of the resources, but when possible, it is important to work as a team. Educating patients and orienting them is important, not just when implementing diets, but also at the time of follow-ups to make sure that they're looking for any, that there's less likelihood of deficiency, especially with very severe, significant restricted diets, that they're screening for comorbid mental health issues, which are important to monitor in our patients who might not always volunteer how they're feeling. But depression, anxiety, especially around food, is something that we ask about at our follow-up visits. The access to specific food resources is important. As mentioned in some of the studies, one of the main limitations of dietary restrictions was the financial implication or the difficulty in carrying out these restrictions based on financial limitations and the expense of more specialized foods. And then, as mentioned, I think it's important to collaborate with other specialists. I am a gastroenterologist, and I know my field relatively well, but it's, I find the input from my allergy colleagues to be invaluable. The input from our dietitians, we say that our dietitians are probably the most important people in our clinic. They're the ones who are implementing and working with families on the dietary approaches. It's very easy for me to say avoid A, B, and C, but they're the ones who will catch that if we're avoiding A, B, and C, you better have X, Y, and Z in the diet, because that's where the holes in the diet are gonna lie. So in summary, eosinophilic esophagitis is a chronic progressive Th2-mediated inflammatory condition of the esophagus. Treatment in short term is aimed at managing symptoms of esophageal dysfunction, but in the long term, it's to prevent the fibrostenotic complications. There are multiple available management options, including medications and dietary restrictions. When talking about dietary interventions, the most commonly used are empiric restrictions based on difficulty with complete elemental diets and poor correlation between testing and induction of remission. And then finally, that several factors need to be taken into account when prescribing restriction diets, including need for multiple endoscopies, the financial burden, nutritional issues, social and psychological impact, and the potential risks of restrictions resulting in food hypersensitivity. With that, I thank you for your time, and I, again, appreciate everybody who listened to this session, and to the organizers of the symposium for inviting me to share my thoughts with you all today. Thank you very much.